Welcome to the JOWMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOWMA podcast. I'm your host, Alisa Minkin. I am a general pediatrician and proud JOWMA member. And today I'm really honored and really excited to be interviewing Dr. Frani Pollack. If there are topics you want to hear, if you want to be interviewed, if you know someone you want to hear being interviewed, or you have comments about any of the interviews, please reach out to us at health@jowma.org. I'm going to try to link multiple talks to this because each one of these talks on eating disorders and related topics is only a little bit of the bigger piece. Dr. Frani Pollack, PhD, LSW, and RD, is a licensed psychologist and social worker. She has been in practice for 30 years. She has worked at multiple inpatient, day treatment, and outpatient programs. She currently works at Bala Child and Family Associates, that's BALA, where she sees individuals, teens, and families. She has also taught and trained students, supervised and ran supervision groups. She currently teaches and supervises dissertations at the doctoral program at the University of Pennsylvania. She also teaches at the Sarah Schneer YU School of Social Work, Council for Relationships, and is a senior trainer for the family-based program in Pennsylvania. She gives talks and lectures in the community and has spoken at multiple conferences. She has written in several referee journals and has co-authored several book chapters. She is certified in EMDR, interpersonal therapy, which is IPT, and EFT, which is emotionally focused therapy, and uses an eclectic approach in her work with clients. Welcome, Dr. Pollack. Thank you so much for joining me today.
Thank you for having me.
Oh, no, it's a real honor. I'm really excited about it. And you really provide a double layer of expertise here because you are a specialist in eating disorder as a therapist, but also as a registered dietitian. So that provides a lot of expertise, two different pieces of the eating disorder treatment. I want to talk about eating disorders, and I do want you to define them, but I don't want to get too much into the definitions and prevention and body image. And these are also important, but I've already covered them extensively. And I'm going to link at least some of the talks, particularly the one I did with Dr. Marcy Forta of Atzmi, I think is the most relevant. But I really want to start, if it's okay with you, with a quick recap of the types of eating disorders.
Okay, that sounds great. So I think a lot of people might know of the main eating disorders, which is anorexia. Do you want me to define them or just kind of name?
Just a quick definition, just so people know what you mean.
So it's usually, a restriction of food and weight loss. A certain percentage of weight loss comes along with it. Bulimia is binging on large amounts of food and feeling out of control, and then somehow getting rid of that food, which can be, the most common might be vomiting, but it also can be diuretic abuse, or also excessive exercise or fasting, which are things people don't think about as much. Binge eating disorder, which used to be in a more atypical category, now has its own category in DSM-5, which is, again, eating large amounts of food, feeling out of control in a short period of time, similar to bulimia, but then you're not getting rid of the food. So those are the three main eating disorders. There's atypical eating disorders, which means they might not kind of fit in exactly into one of those categories. But they're still considered eating disorders. They might be like one less thing than the one less criteria than anorexia or bulimia, which puts them in an atypical category. And there's also disordered eating, which is not an eating disorder, but it might be on the way to an eating disorder, or it might have certain categories of an eating disorder, but it's not as severe, and we might see that a lot. So those are the main kind of categories of eating disorders.
Yeah, that's great. That's a great summary. There's also ARFID, the avoidant restrictive food intake disorder, which I'm seeing more of as a pediatrician, where they don't necessarily have body image issues. They're not necessarily trying to lose weight, but they are severely restricted in their food intake, types of food, amount of food sometimes. And there's also orthorexia, which is a rising category where it's dieting gone amok, where they're really very abnormally focused on the types of foods they eat for health reasons, supposedly.
Right,
so they may eliminate many categories of food. So those kind of overlap. And those are the newer kids on the block in the eating disorder world, to be quick. And I definitely have done this already.
Thank you for adding those.
Yeah.
Oh, is that?
Yeah, and I
Yeah.
also want to add something very, very important, which I think atypical anorexia is a useful diagnosis for, is that I think especially clinicians think of anorexia when they think of eating disorders, and then they think of a thin, teenager. And atypical anorexia, you do not have to be underweight. I'm not sure if that's even atypical versus regular anorexia, but I think an important take-home point is you do not have to be underweight.
Yeah, I think that's very important. I mean, I've seen a number of teenagers that have, I would say, might be considered very large, but actually have anorexia
Hmm.
because they fit the other criteria. They've lost a significant amount of weight very quickly, on a very restricted diet. And it's something that can be missed if you're just looking at size.
Right. And it doesn't mean that they're less at risk, right?
Absolutely.
I do
Yeah.
believe that their morbidity, and the amount of sickness they have, and even the mortality is very high in that group as well.
Yes. Yes. And it's easy to miss. So, yeah.
It's easy to miss. And I'll tell you one reason why it's easy to miss as a pediatrician, because when we look at the growth chart, we get, in most people's electronic medical records, I believe, you get a number, you get a percentile. So you'll look and you'll see the BMI is 85th percentile. You'll think, whoa, they need to lose weight, right?
Right, right, absolutely. But I think one thing to think about is what is it relative to the weight before, right? So if people are dropping
Exactly.
weight super quickly, I mean, somebody that might be obese, if they're dropping weight slowly and you do a 24-hour food recall and you're hearing what they eat and it's, fairly reasonable, that's fine. But if they're dropping weight very, very quickly and you realize that they're eating, 500 calories a day, that's very concerning.
Right. And I think just, again, as a pediatrician, I'm putting my little pediatrician hat
No, please do.
in
Please
the
do.
ring
That's
here.
great.
Yeah. So I think it's important. I like to look at the trajectory, but it involves a couple of more clicks and we're busy. But you can at least look at the previous weight.
Absolutely. Ideally, like the growth chart, which you know more than I do, and the weight chart, where you're really seeing, but certainly at least the last visit um is
Yeah.
very important.
That's a downside of electronic records. With paper charts, you would see it. You would
Yeah,
plot it.
yeah, I hear
And now
that.
you have to go into the further into the EMR and you have to do a bunch of other clicks. And I don't know that everybody does it. And in mine, by the way, if you go into it and you don't click the right thing, you freeze and shut down the entire computer.
Oh, okay. Yes, I hear some of
Yeah.
the challenging technology.
This is very specific. I'm sorry.
Okay.
Okay. So let's talk about some things that parents and clinicians can look for to detect an eating disorder, because after prevention, early detection is so important.
Right. Early detection, I always want to emphasize, is really important because if you detect it early, you can turn it around much more quickly
Yes.
than if it's detected later. The longer it lasts, the harder it is. And that's just very real. So we don't want to wait on that. So, I think parents and clinicians are a little bit different. So I think with clinicians, and you might add to this as a pediatrician, but obviously, yes, looking at the weight chart is very significant if you can with technology, getting a sense of what, if you have some concerns as a clinician, a pediatrician, you want to get a sense of what the teenager, probably it could be somebody younger, is eating. So doing even a 24-hour recall of food is really helpful. Can you give me a sense of, what a typical day might be like? Maybe yesterday you can tell me what you're eating and you want to get a sense of how low that caloric intake is. I think being curious, open-ended questions, not being judgmental or showing too much worry is helpful because people don't always tell the truth that have eating disorders, particularly if they're more in the anorexic category or bulimia, actually binge eating as well. So you want to try to create a pretty accepting atmosphere as a pediatrician or a family doctor about what people are eating. So you're getting like a truthful recall. And obviously between the weight chart, the BMI is used a lot. That actually is used to determine, I think one thing that's very significant in DSM-5 is that now we have these different categories of eating disorders, mild, moderate, extreme, severe, based on a BMI. It's not the only thing that it should be based on because people can have different BMIs, genetically, but
Hmm.
it is one criteria to look at. And it gives you, if you look it up as doctors, it gives you the number of what would be considered, mild or more severe. And it is a helpful criteria. So definitely looking at weight and height and figuring that out is helpful. And relative to what they were before, of course, you're looking at the relative BMI. I think as a pediatrician, you're also doing different kinds of tests, which you could probably name better than I, but in terms of psychology and food, I think a quick test is just getting a sense of their food. You might even ask the parent too, because the parent might say, well, I notice they're skipping meals, or I notice a bunch of wrappers in their bedroom, which is another sign. Parents will often say to me, I was cleaning up and I noticed, all these wrappers in the closet or in the trash can over 24 hours, like a lot of different like candy wrappers or donut boxes, you know, whatever it is, which might lean more towards binge eating or bulimia. Or I've noticed the parent might say that right after a meal, my daughter is always in the bathroom for 20 minutes, like
Mm-hmm.
immediately after, which could be a sign of bulimia. So,
Mm-hmm.
you know, any kind of food changes, either you're noticing, you know, coming to the parent piece, you're noticing they're eating a lot less, you're noticing there's a tons of restriction. You know, look, kids can restrict food because they would just want to be healthier or they want to be a vegetarian. So it doesn't mean that they have an eating disorder. But if you're noticing those things with a lot of, you know, eating less food, not wanting to come to meals as much,
Mm-hmm.
skipping meals, going to the bathroom a lot, those all can be different signs. You're noticing weight drop, you're noticing or weight gain, you're noticing clothes fitting differently, sudden weight drop, sudden weight gain. Um, I think those are all signs, and often they can come with kind of more irritable mood, more
Mm-hmm.
isolation socially. It could affect school, not wanting to go out as much. You know, there are usually other signs that might go with it.
Mm-hmm. That's really helpful. And there is a high association of anxiety and depression.
Absolutely. There's a high comorbidity with anxiety and
Yeah.
depression that might even come first. Or there could be an incident that occurred that you are aware of. Sometimes there's no incident, so it doesn't. But if there was a huge strain and let's say a social piece at school, or there was a trauma, or you know anything else that might have occurred, it could be coming along with that or not. Um, you know, it does sometimes if a child might feel a little bit heavier than their peers, you know, that could also be, you know, a trigger to feel like I need to lose weight and then it could go, you know, too far. Or it could,
That gives me a chance to say to pediatricians and other clinicians, be very careful about what you say. When I mentioned the 85th percentile BMI, I was not saying that I believe that everybody who scores at 85th percentile BMI, quote, needs to lose weight. I was just mentioning that that could be a conclusion because we're so driven by the BMI, but I think you have to be so careful.
I can't emphasize how careful you need to be. I mean, I've been seeing somebody recently who was hospitalized with an eating disorder that fell into the category that you would say of somebody that was, you know, what we consider very large, their BMI was high, felt uncomfortable with their weight compared to the peers, and started moving into a kind of an atypical anorexia,
Mm,
and needed to be hospitalized, and then came out in a really good place, I'd say, in terms of eating regularly and maintaining an okay weight, but went to see a pediatrician that did really not know about eating disorders, unfortunately, and saw her weight and said, "You really need to lose weight,"
mm.
which was like a terrible trigger.
Oh, oh, that's awful.
Yeah, so I think that, you know, we have to be very careful. We have to look at the history of the BMI. If there's a therapist involved, if you're a doctor, to really make sure you're talking to that person to get a sense of the history, because or talk to the parent. You know, those lines from a pediatrician can be very harmful. And I know people have the best of intentions, of course, always, but we just have to be careful given the prominence of eating disorders to make sure that there's not an eating disorder going on as well.
Absolutely. And that brings me to disclosure and talking about it. I want to talk just for a few minutes about how important it is to be open about this.
To be open about it, you
And
mean
I
as
don't mean to the whole
parents that,
world. I mean, say, for example, this person came to the pediatrician and that pediatrician didn't know
right,
that she had a history of an eating disorder.
right. I'm not sure it was a new pediatrician. You know, the parents didn't tell her. I was later in touch, but
But the
um,
parent, I'm sorry, but the parents didn't tell her. I want to focus on that for just a minute
yeah,
because
good
there's a
point.
stigma for this, and
Yeah,
there's reasons why people may not want to talk about it. And I think that not everybody needs to know, but people working with that child do, and that may involve the school as well.
yeah. I think, and maybe we can use the terms privacy versus secrecy.
Hmm.
I think secrecy is something where no one can know. And sometimes it's only the, you know, the person that's holding the eating disorder, or sometimes it's that person and maybe the parents, and that's it. Even the rest of the family doesn't know, the doctors might not know, the school doesn't know, and that can be harmful when something is a secret and there's fears, right? Like, oh, if
Right,
people know they're going to judge, or if people know it's going to affect marriage proposals or whatever else. So
right,
that's like a secret. Whereas privacy, which is reasonable, is that we don't have to tell the whole world about this. This is something private.
right.
But who are the people that we can tell that are important in terms of support, like other clinicians for sure that are involved, any kind of doctor that's involved, or a nutritionist or anybody like that. But even people that care about, you know, the child, you know, a teacher or a nurse at the school. or the principal. Like there might be other people that need to know, or even a close aunt or a close friend, because for support, for added support. So we really have to think about, when something's a secret, it's generally harmful. When something is private, and who are the select people that we can tell, that we trust, that can support our daughter or son for that matter, with this eating disorder. So I think that's the way I would think about it, because we work as a team, and
Right.
certainly the school needs to know often, and I think can be trusted to not, tell more people.
Right, to be discreet. And you use the word team, and I do want to get to build your team. That is actually what I want to talk about. And that is, what should you do when you do suspect an eating disorder? And this could be for the clinician, it could be for the parent, it could be for the teacher, a friend.
Right.
It's
What should
many
you do in
different
terms of
people.
so what should you do if
What
you
are the
know?
first steps? Can you walk us through it?
Yeah, so it depends who it is. I think that the doctor, the pediatrician, the family doctor is probably the best first step,
Hmm.
and it might be important to say to them, have you worked with eating disorders? Do you, just so you're making sure that you seeing someone, like if you suspect it as a teacher, you say something to the parent. As a parent, you bring your child into the pediatrician and ask, do you work with eating disorders? Do you understand? I'm worried. And that to me is a good first step.
Wait,
If
I'm
you
just going to put in, and if you're a student, you don't keep it a secret.
if you're a student, you don't keep it a secret, right? If you're a student and you worry that you have an eating disorder,
No,
you
no, I
tell
meant
some.
your friend does. Your friend does, and you're keeping it a secret because you don't want to tell anyone.
Okay, right. So yes, exactly. Um, and then I think because the pediatrician or the family doc can also, look at some of the medical pieces to this, as well as the BMI, and ask, appropriate questions, so they can do like a more comprehensive assessment. Hopefully, if they don't know a lot about eating disorders, we might want to refer to someone who does. The other option in the first step is to find a clinician, a therapist who knows a lot about eating disorders and knows how to do a good assessment. They're not going to do some of the medical pieces, which is why I like the doctor involved, but they certainly can do a good assessment in terms of really figuring out how severe the eating disorder is, if there is one. Is it more disordered eating? So I think every doctor, by the way, should have at least two therapists that they really trust, that can do great assessments, that have experience with eating disorders, and two dietitians, nutritionists who are also really experienced with eating disorders. I think you should just have them as referrals. If you don't, find them, so that if you're not sure exactly what's going on as a doctor, you could at least say, I would like to also have you see this nutritionist or this therapist, because I want to get another opinion on this, right? You don't have to work alone on deciding this. So I'd say that's the first step. The next step is really like, once, if there isn't an eating disorder, okay, we're good. If there is, where it is significant. Like, is it a more mild?
I'm sorry, I just want to go back for just a minute. That's really helpful, but I want to go back for just a minute because I think that one stumbling block point is where you go to the physician, clinician, whatever, and they say, "Oh, your child's fine."
And you don't think they're fine.
Right. You're
Yeah,
still worried.
you're still worried. So, okay, thank you. That's good. You could try to get a second opinion. Especially, again, there are doctors that actually specialize or have a lot of experience with eating disorders. That's there. You could even say to your doctor, I'm still a little worried. I wonder if I could see somebody that has a lot of experience with eating disorders, just to get a second opinion. Or again, you can ask a clinician. Like, I think I can assess an eating disorder pretty well, even though
Hmm.
I'm not necessarily doing some of the medical workup, but I can have the doctor do that. So then you can request to see, I would say, a psychologist or a social worker that's licensed to who has a lot of experience with eating disorders. And if you're a school principal, you should have that list also.
Mm.
Who are the best pediatricians, the best therapists, nutritionists that have a lot of experience with eating disorders. And I'm emphasizing that because you can be a great therapist or nutritionist and not really know much about eating disorders.
Right.
That's not the person you should see. And I think one other area that I have seen a lot is someone that goes to a doctor, the kid has a lot of GI problems and they're losing a lot of weight,
Hmm.
can't eat, they're hurt, and the doctor thinks, okay, it's a GI issue, which is reasonable. And then they go to a lot of GI docs, sometimes many, who, like, sometimes there is, comorbidity with the GI disorder, like gastroparesis from not eating much.
Or
You
IBS, right?
or not eating and then binging at night, you can develop. And that they think it's a medical issue. And it's not until sometimes they land in an experienced therapist's office that they can detect, no, actually, this is an eating disorder. Yes, there are GI there's some comorbidity with some GI stuff, but the essence is an eating disorder.
Right.
So
Also IBS, by the way, irritable bowel syndrome.
100%. So just know if there's a lot of GI symptoms, they could be coming along with an eating disorder. It's important to know for pediatricians and for parents as well.
I'm going to say, because I'm going to just be really honest here, we have very little time as pediatricians. And I don't know how many pediatricians have a lot of experience with eating disorders. And
Okay, no,
so
I appreciate you saying
I'm being
that.
honest here.
Right. And I appreciate you saying that. And for, to be sensitive to pediatricians, if you have time, maybe it's one of your CE, courses, because it's becoming so much more common. But if you don't have it, that's okay too. Just have your list of people that have a lot of experience to refer to. If you think there might be something going on, you can say, hey, I think it might be valuable to have a session with, this therapist.
Right. And again, part two this is not the fault of clinicians. It's just not that there's limited time. And we have a very siloized system. So if someone comes in for GI complaints, you're going to focus on that because you only have a few minutes.
I got it. But
the point that I'm making, I just want to finish the point I'm making. The point that I'm making is a shout out to parents to not let go of your concern. Don't be dismissed.
Okay.
That's the point
really,
that I'm
really
getting to, because
important.
sometimes you have to advocate harder in a challenging medical climate.
Right.
This is not a matter of fault. This is reality.
Right. Absolutely. Absolutely. And as a doctor, you could think, hey, even if you don't have a lot of time, could this be a GI issue? Could it be an eating disorder? I'm going to maybe recommend to the parent to follow up with both.
Right. But in order to think about eating disorders, you have to ask those questions.
Yeah, absolutely. Absolutely.
Are there like a few really quick questions that could bring it up as opposed to a 24-hour recall?
A quick question, for the kid, for the
physician or clinician.
Really, okay.
To pick it up, as somebody comes in and they have IBS symptoms, you're going to think it's IBS. Why would you suspect an eating disorder? Somebody comes in their normal weight. Why would you suspect an eating disorder? You can't get a 24-hour food recall or a long set of questioning on every kid.
Right. Yeah, it's hard. It's hard to maybe minimize it to like one or two questions, but I'll throw out a few. I mean, one thing you could say is, it's so hard. I'm just thinking like all the questions I'd ask, which would take up an hour, but
but that's the whole point. We don't have that.
Yeah, exactly. So what, if you think it's a GI problem, you could ask, first of all, is there any kind of family history, related to that you would probably know. And just, you could just ask an open kind of question. What happens when you eat? Tell me a little bit more about, oh, well, every time I eat, my stomach hurts. That doesn't feel right to me. That's like every time you eat, your stomach hurts. I don't know, maybe certain foods, because maybe there is some kind of, allergy or medical reality. Every time I eat, okay, so are you eating very little? Yeah, I hardly eat because my stomach hurts all the time. By the way, one of the main treatments for anorexia and sometimes bulimia, if there's a lot of fasting and then binging, is I just say to people, food is medicine. It is going to hurt sometimes, because they will tell me that this is not about enjoying food or feeling good.
Right.
This is about eating because your body needs it and your brain needs it. So I'm not, and so I think that like, you want to get a sense, is the eating like all foods? Yeah, it doesn't matter. That would be like something for me that I wonder about, or they might say, it's really just like when I eat dairy foods or junk, my, I don't know, is it specific foods or all foods, I guess, is one criteria that I'd wonder about. Does it mean that they have an eating disorder or don't? But I'd wonder about it. I wonder if it was like a sudden onset, like, yeah, I've been fine, and all of a sudden, like last week, everything hurts me. Like, well, that doesn't make like complete sense either. Or was it like a gradual onset? Did something happen recently that might have contributed to it? Something more social or environmental? Yeah, I had this horrible trauma. I'm not saying they say that, and I now my stomach hurts all the time. If there's a connection to something. I know there's not a lot of time, but those are some of the questions I might ask.
That's helpful. I'm surprised you're not bringing up body image statements.
Yeah. Yes. So body image, are you talking about with the pediatrician or with?
Yes, that, how do you feel about your body? Is that a good question?
Absolutely. Absolutely. So that's another good criteria to ask. How do you feel about your body? How do you feel if they've lost weight or gained weight? How do you feel about your body now? How did you feel about it before? Again, in a very curious, non-judgmental way, you're going to likely get a better answer. Though I know that you don't have a lot of time as a doctor, but I think you can ask that in general, or even a question like, how do you feel about your body? Do you feel like you need to lose more weight or gain more weight? Do you feel good where it is? How did you feel before whatever weight change there might have been? So if somebody is like already with a low BMI and they're like, no, I really need to lose more weight, I don't feel great, that's obviously like a concerning
Right.
sign. If somebody has I've had somebody with a GI disorder and it was questionable if there's an eating disorder and had lost like 10, 15 pounds and of normal weight, they were normal weight, normal BMI. And she said, I don't want my body this thin. I want to gain weight. I just have so much, pain in my stomach. So that was a sign to me that, oh, maybe it's more of a GI disorder. The fact that
Right.
they want to gain this weight back.
Right.
They don't feel good. So I think I think it's a good point you're making that combining a quicker question or two about body image also helps you to understand how much of this, because almost anybody with an eating disorder, not everybody, has some kind of body image issue also. So if you're trying to discern with a GI symptom or something else, that's a good question to ask.
Right. And you could also, this is so obvious, but you could also just directly ask about binging, purging, all those things.
You can absolutely ask them, and no, people might not be telling you the
Right.
truth.
Right.
But absolutely. And again, the more you have a connection with the child,
Right.
the more you're not judgmental, the more you even normalize it. A lot of people do have like challenges with food and weight, in your age group, and just wondering if sometimes that might lead to, feeling like you're eating large amounts of food. Like, what do you think? You're trying to create not normal, because it's still an eating disorder, but you're trying to make it like more receptive to the person being honest with you.
Right. And if you're the parent and you still suspect it, you can go get outside help, which might be a therapist, to really figure out what's going on. Again, the
Yeah, I mean,
doctor is
you
not the
as a
therapist. I'm
Yeah,
going to say that
100%.
again.
The doctor's not the therapist. The doctor's often the first person you might go to. But
Right.
the doctor should have a list of therapists you could talk to that specialize with eating disorders. I'm sorry, I keep mentioning this,
I'm
but I
gonna,
think
but
it's
I'm gonna,
very
I'm gonna be
important.
really blunt again, because this is the real world that I live in. It is so hard to get a therapist for anything. And when you're talking about eating disorder therapy, it is how much more so. It's really hard. It's not just something we can have at our fingertips.
Well, I want to be empathic to that, but I'm sorry, I just can't agree with it, because I think you can ask around in your colleagues and get two names that take a minute to give to a parent. And I think we just have that responsibility. I mean, I feel the same when I have to refer for this disorder or that disorder when I might not have expertise. And I just think it's our responsibility. I'm sorry if I'm being a little bit
No. And I
hard on
want you to
the
be, I want to be really frank, because I don't think it helps us if we don't give really honest
right. So
advice. I'm not
I
saying we
think
don't
it's,
have therapists. I'm saying that they don't take insurance. They don't have
yeah,
spots open, that kind of thing. We have lists. And we actually now, from the practice I'm in, we have a service coordinator.
amazing.
And there's a
Wonderful.
2-week wait list to get that person to do it, because there's not many people that need help. And it's very, very hard. And in our area, we have basically almost nothing for eating disorders. I just found, I'm going to give them a plug here. I'm going to give them a free plug, because I'm so excited to have
Go
them.
for it.
We have, and now I'm going to forget, I can't believe it, Equip.
Okay,
We
well, you
have
think
Equip.
about it for a minute, but I just
No,
want to say
Equip,
there's
Equip.
Equip. Okay, that's
Equip
great.
is an
Equip, give a
online
free
eating
plug.
disorder program, and that is where we started to refer, because we literally did not have anyone that took insurance and had expertise in eating disorders before Equip. But it's online,
Okay,
it's not in person.
amazing. And I obviously just want to say before you said that you will expand your possibilities if you do online
Right.
work, right?
Right.
So, and you might need that at least initially to get a good assessment until you find somebody that can take you in a month. But I do think once you look at online, there's a lot more options in the state that you're in.
Right. But it is a reality that eating disorder programs tend not to take insurance, and not everybody can afford that. I'm just being really frank. I
Great.
think it's important.
I agree with you, and I think that's we're talking about programs, but I think that if you catch it early in the more mild or moderate time, you might not need a program. You might just need, a doctor. I'm on a lot of teams because I'm an outpatient clinician it's me, a doctor who knows about eating disorders, and a nutritionist. Sometimes it's just me because it's mild enough that I can, handle the food and the psychological piece. But so that's outpatient. I'm not saying that's not cheap, but it's not the same as like a program that you're paying for.
Right. No, that's
93.
what I'm talking about. Right. I mean,
Yeah.
Equip is an outpatient
Yeah,
online program.
Yeah. So I think that it's just like the sooner you catch it, the more likely you're going to
Right.
be able to, really do a program that's going to be less expensive as well.
Right. So let's go through. We started talking about treatment, but we didn't list all the different options. We're kind of alluding to them. Can you walk me through the different options, please, and who is appropriate for each type?
You mean in terms of
For treatment, we're up to treatment.
the clinicians? You're talking about the kind of clinicians or the kind of treatment that we'd use?
Both.
Okay. So if it's a very, mild eating disorder, which means, that they might, or even before that they're moving towards an eating disorder. Somebody just called me recently. It's somebody I knew that their child, sounds like their BMI was actually okay, but is actually a boy. So I just want to bring that in because even though there are many less of them, he's a teenage boy, they do exist. Their focus might be more on like being more muscular or slim or lean, but nevertheless, they can fit into some of the criteria. And certainly binge eating disorder and bulimia, especially if they're on a sports team, and they have to be a certain weight to be in this. Wrestling is a big bulimic category for boys. But they called me and it sounded like they didn't quite yet have an eating disorder. They're moving towards that. And so my recommendation was, hey, I think you just need to see a nutritionist that's really knows a lot about eating disorder and just get this boy on a really good food plan. If that doesn't work or he's not willing to, then we'll take the next step. So I gave her, the mother, a number of names or several names of nutritionists that know a lot about eating disorders and even a little bit about psychology to integrate in. So I think that's, pre-eating disorder. Just let's get the food together. Let's educate. There's a lot of education about the importance of food, nutrients, for your mind, for your body. Sometimes that's enough. Maybe a step up from that is, again, if we're pre-eating disorder, disordered eating, or maybe more in the mild category, you might see a therapist with a nutritionist. That's like the first step. If it's, again, in the more mild range, the BMI is not still lower, but it's not terrible, whether it's anorexia, bulimia, or binge eating disorder. And the nutritionist will help with creating some kind of food plan that's healthy for whichever eating disorder it is and works with, when I say team, means we talk to each other. And we say, we get permission to talk to each other, and it's very helpful to have somebody else on the team because you have somebody to bounce ideas off of. There's also often a doctor involved just to monitor, some of the weight and some of the blood pressure, blood work, whatever. And then the therapist might just look at what are the kind of, possible issues involved here. Could it be just, to be honest, sometimes there's just stress being a teenager and there's no other red flags. And, maybe stress being a teenager or stress with school that might contribute to developing, some of this irregular patterns of eating. Sometimes it could be more. There could be a lot of, maybe there's some family issues or stress that could be contributing. There could be serious social issues that are contributing. There could be low self-esteem that's contributing. There could be a genetic piece or a family piece around weight that's contributing. There could be a trauma that this is where secrecy is very big, that, if there's any kind of abuse going on, which does occur, whether it's within the family or outside of the family, and that's where the secrecy can be really strong. And it's taken sometimes in my work, I might be with them for quite a while till they acknowledge abuse, because that you really have to feel a sense of trust, even if I've asked, because I'm wonder about it. So then you kind of, as a therapist, will know, what direction to work on. And I can, if you want me to name a couple of treatments that have been successful.
Yes, I just want to make one point since you gave me a break. This is fantastic. You're doing great.
Sorry.
Trauma, the association of trauma and eating disorders. And I know that's one of your specialties, right?
Yeah. I mean, there's definitely comorbidity with trauma. Doesn't mean that everybody has had trauma that has an eating disorder. I mean, at all. But it's something you certainly want to assess for, because there is a decent correlation with trauma and eating disorders. And so you want to just see, and you want to know, whether you're a doctor, a clinician, or a mom, or whoever you are listening, that they might not be honest with you, because there's so much shame often, even though it's obviously not the child or the teen's fault in any way if there's trauma, but it still can be a very shameful thing that has happened or is continuing to happen. So just, we want to keep it in mind. And, perhaps if you're going to ask, to make sure, you're in a very private setting and you're, again, very compassionate and you're very understanding. And if they say something that's shocking, which it might be, to be just very loving and supportive. Thank you so much for telling me. I know that was probably really hard. We're going to work on this together and really help you through it. But again, it's not the case for a lot of people, so I don't want people to jump, but it is something that I would want to assess for.
Right. There's a higher rate of it. Let's,
There's
to
a
put it in
higher rate of it,
one
so we want to
sentence.
check it out.
Yes. And trauma-focused care should be universal. But anyway.
Yeah. Yes. Yeah, 100%.
So you're going to talk about the different types of treatment, just in brief, and I'm going to interview someone else. So don't worry, we don't have to go into great depth. People listening can know there will be another one.
Yeah, okay. I mean, I think the most common, again, different eating disorders might have different treatments. So cognitive behavioral therapy is generally a treatment that's used, that's been supported in research for all eating disorders. So that's sort of the most common treatment. Interperson, which is all about a lot about, some behavior change and also looking at your thoughts and cognitions that might contribute to an eating disorder. Like the most typical is an anorexic who's quite underweight who thinks they're fat, right? That's a cognitive distortion. Or somebody, let's say, who's larger, who has binge eating disorder, has a thought that I will never get married at this weight, which is also a cognitive distortion. People get married at all sorts of weights, so I think that it's challenging cognitions and it's working with a lot of behaviors, cognitive behavioral therapy. The other therapy that's really for bulimia and binge eating disorder, not for anorexia, has been shown to be very helpful as CBT, is interpersonal therapy. It was first used with depression, and now it has also been shown to be helpful for bulimia and binge eating disorder, which is a lot about, looking at how relationships might affect eating disorders, which could be like a bad relationship we have that we're really close with, maybe teens fighting with their mom all the time. That could actually contribute, or they're socially isolated. The theory is that relationships are really important. And if we have some kind of stress related to a relationship, we want to heal that because that could be a contributor. So that's another research-based. Obviously, the family-based therapy, the Maudsley method, is become very popular for anorexia.
Yeah. Right. What about DBT?
So DBT also has been shown to be successful. It was created for a more borderline personality disorder. So I would refer DBT more if somebody might have some of that personality disorder with an eating disorder. But that
does also comorbid with it, so that's not uncommon.
Yeah, no, it's more comorbid, with bulimia, I'd say, but
right.
It's
or binge eating.
Yeah. But yes, I think DBT is great. It's a more intensive treatment, so I think it just depends. I think I'd ask a clinician, would CBT be better? Would DBT be better? That's where you have to discern those.
Right. It also matters how well the kid is doing, right?
Yeah.
I mean, it is more intensive. It is more expensive, harder to get. These are all access issues.
Yeah, it's more intensive, but it does give you a lot of different skills. The Maudsley method, family-based therapy, is been shown to be really effective with anorexia. It's probably the most effective treatment right now on the market for anorexia. If you have somebody living at home, usually a teen or preteen, and it's a family-based treatment, which the parents are so you have to really discern, are the parents able to really implement this? Because it does involve parents practically that they're home, and it's more complicated than my 30-second explanation, but it's the families involved with refeeding the teen, so that the younger child or whatever it is, so that which is typically done in a hospital setting, but they're doing it at home so the child can still be in the home and not have to be hospitalized.
Right. Is family-based therapy all the Maudsley method, or are there other types of family-based therapy?
Well, family-based therapy is a word that's used for other kinds of therapy that don't have to do with eating disorders. So that's why, but it is called family-based therapy, and it's also the Maudsley method. So I'm using them synonymously, but the Maudsley method is this method, and family-based therapy, like I do a lot of family-based work that has nothing to do with eating disorders. So that's like a bigger term.
Right. The reason I'm asking is because the Maudsley method is very intense. Not all parents can do it, right?
Yeah, that's what I'm saying. It's not for all parents, but I do think it's important to know it is research-wise the most effective treatment for anorexia if the child's living at home.
And if the parent can do it.
And if the parent can do it, both psychologically and practically, because it means the parent preparing the food, presenting the food, and trying to stay calm during. So it's not easy. And if people are more interested in this, you could just look up some YouTubes on it. Maudsley method, family-based treatment, and you'll see like there's a lot of good videos on it that you can get a sense of how it works.
Right. The reason I'm pushing on this is because I do see with anxiety and eating disorders a strong family interaction component. And so I'm
Right.
wondering, are there other therapies that involve families to be involved rather than just working with the teen, other than the Maudsley, which not everybody can do?
I hear what you're saying. Yeah, 100%. So I guess when I'm talking about treatment, when I say therapy, it's often a mix of individual and family therapy, which is not Maudsley.
Okay.
It's family therapy in terms of learning how to communicate better and learning how to hear your teen better. It's not how to, Maudsley's all about the food. So there's other dynamics that are helpful and healing that are not about the food. And I want to say two things on that. One is that there could be family dynamics that contributed to the eating disorder prior to the eating disorder. Right? Let's say, for example, there's a ton of fighting between the parents and they're on a verge of a bad divorce, right? That could contribute to the eating disorder. It's not a way for parents to blame themselves. Things happen,
Right.
but if they understand it more, and how the fighting could affect the teen and the eating disorder, that's important. But it also could be that after the eating disorder, more tension occurs in the family because of the eating disorder. So everybody's more anxious and everybody's more worried, and there's more fighting between the siblings because they're upset that this teenager is getting more attention, or who knows, or the mother leaves work because she's worried about the eating disorder and then she's more stressed. So either way it could happen. And again, family dynamics prior to the eating disorder or after the eating disorder has occurred. And I think it's just, I'm always sensitive to parents as a parent myself, but like we tend to blame ourselves. So this is not about blame. It's just more about, oh, wow, there's things going on that I can maybe change that will help my child. And maybe doing some family work
Right.
can be helpful. We all can work on ourselves, and I think we won't, because a lot of times people will avoid family work and just like fix my teen. And usually there is some family
Right.
piece. I would say almost always that we can work on to help the situation. That again is not Maudsley. It's just some family dynamics that could be helpful.
That's really helpful. I'm really glad you explained that. Let's go into the higher level care because there is residential treatment. Who needs that? What is that?
Right. So I think if the eating disorder is more, severe or extreme, which again would be determined probably by the doctor based on BMI and other criteria, then we have to start thinking about, or you start with like a therapist and a nutritionist outpatient, and it's not working. The person's still binging, still purging a lot, still dropping weight. Then you have to think about a higher level of care, which is often determined for me. I will often work with the pediatrician or the family doctor together, and we'll decide, what's best. Or, I think it's good to do in a team. Like, yeah, we think at this point they need a higher level of care. That's the term, often a higher level of care, which the first step would be maybe a day program. So a day program would be like 9 to 3. Sometimes they have a program like 5 to 9. If it's 5 to 9, the person can still be in school, but do this in the evening, or 9 to 3. And the reason for that is it's more intensive. So if you're more concerned, if it's more, again, in the extreme or severe level, it's going to be more helpful. And also because you're actually eating in the program. If it's a 9 to 3, you're probably eating breakfast and lunch in the program. So somebody's helping you and supporting you around the food, making sure you're not binging afterwards. I'm sorry, binging or purging afterwards. So it's making sure those nutrients are going in. So that would be the next step, would be like a day program. And the step after that, again, if that wasn't effective, if people weren't really working in the groups, if the clinicians, saw that this person doesn't seem to be getting better, then the next step would be an inpatient program, which would be some kind of residential where you're living there, or hospital program, which is like the sort of last step. Again, I think the more we can catch this early and deal with it better, so we don't have to go to those, but those would be the last steps.
Right. We can't say that enough. You could say it again if you want.
Catching it early and getting into help as soon as possible.
Right. Are these programs covered by insurance?
Some of them are and some of them are not. Sadly,
Right.
probably more are not, but and that's where it can get like really expensive. Obviously, the day programs are less expensive than the residential programs. But some are covered, depending on the insurance and how good the insurance is.
Right. And it also may only cover it for X period of time. Right.
Yeah. Yeah, absolutely. Absolutely.
Okay. So
Yeah,
now we have to deal with the reality of kids in our community who primarily the ones with eating disorders are in the community. They're not, in a private school somewhere for kids with eating disorders. They're with everybody else. And so my next set of questions is how do we balance supporting this teen with an eating disorder in their mainstream program with the needs of the other classmates? Because there is this issue of contagion, right?
there can be an issue of contagion, which means other people are noticing this and seeing this and might start copying. That happens also in eating disorder centers, unfortunately. There can be.
Right.
So I think, I mean, the first thing is if somebody doesn't have a need, if somebody has not been labeled with an eating disorder and is just hardly eating and is at lunch with everybody, that can be more concerning, right? Because everybody's saying, oh, this teen has lost all this weight and look how she's not eating, and maybe I can do that too. So we certainly, as teachers and administrators of schools, we want to notice that, like, wow, that she's not really eating very much, or he's not eating very much, or she's eating and then I notice she's like, walking 10 miles afterwards or whatever it is. We want to notice that and catch it immediately and talk to the teen, the parents, and really try to figure out what's going on. So that stops the contagion, and also it helps the child with the eating disorder. If the child already has been given an eating disorder diagnosis and is working with a team, then I think it's a little bit different. I mean, I've had many teenagers I've worked with where they are able to live at home, and we're doing maybe some version of the Maudsley method and therapy. And I have them eating actually separate from classmates with the nurse in the nursing office for lunch until we are really sure that they're eating all their food. So we have to think about that. Like, can we pull in the school? And does the child need to eat, privately? And the nurse will make sure, or it doesn't always have to be a nurse. If the school doesn't have a nurse, it could be a different teacher, to make sure the child is eating. So I guess I don't see the contagion or copycat lasting very long because one, if you're noticing a kid's not eating and you're a teacher or administrator, you're addressing it right away. If they are already in treatment, they have to show that they can really eat their meal with their peers. And if they can't, they have to eat with a teacher or a nurse.
Thank you. You know what I'm getting out of this is that I think that people think, I know this kid has an eating disorder and I'm scared of it and I'm worried about it, but they're worried about the wrong thing. They should be more concerned about the kids who aren't being diagnosed and treated.
Yeah, I think that's true. And
right?
that's where I'd say sometimes in certain kinds of schools, or even in sometimes in the religious community, it can be more of a secret. And the more we can do education, that's where education is. I think it's really helpful for schools. I think sometimes people don't educate about things because they're scared. Oh, if we talk about this, then maybe that'll contribute to it. And that goes along with eating disorders or suicide prevention or depression. And I don't think there's any research that says if we talk about it more, we're going to have more. Actually, I would say it's less. The more we are knowledgeable about it, both education for parents, there can be education on school nights, or education for kids about this is what happens, this is what can happen. This is really concerning. A little fear here is not a bad thing. And this is what we can do for prevention if you notice yourself. I had one girl that there was education in the school, and she went to her mom and said, listen, I think I might be developing an eating disorder.
Wow.
Because I had somebody come speak, and I think I have some of those. And that was amazing, right? That one, they had the education at the school. The two, that she actually went to her parent to say, I'm worried about myself. Can I see somebody? She felt close enough to the mother to do that. So that's what we want to see. The education, kids may be talking to their parent, or a counselor at school. That's a lot of the prevention.
So I want to say, though, that I found a great resource accidentally from the National Eating Disorder Association, and it is an entire section on how to and how not to do eating disorder presentations, because there are dangers if it's done the wrong way.
Okay, do you want to share any of that? Because that sounds great.
So I didn't finish reading it. Sorry. No, but I'm going to link it to this talk and I will send it to you.
Thank you.
But you made a great point about how kids can pick it up themselves. Friends can pick it up in others when they're listening to it, thinking their friend has it.
Yeah.
And so I think it's important to have a culture of a school where we all are supporting each other, where the kid can go to some administrator, they know where to go and say, I'm worried about so-and-so, as opposed to keeping it a secret. They're aware of it. They know what to do, and having a really good presentation, one that is not triggering, but one that is truly educating, and the parents as well. So I'm going to link to that. It was huge. There's so much to do
No,
and not
thank you so
do.
much. And yeah, and that
Yeah,
makes a lot of sense because there can be things that can be triggering and things that can
right.
be helpful. So that would be great.
Right. So it's not whatever you do, you're not going to, cause a problem. It's
Right.
actually very tricky.
Yeah, yeah, I bet it is. I bet it is. I don't do a lot of those talks in schools or, I've done them more in the past, so I don't know all the specifics, but I do think it's really important that if schools are having somebody come speak, that they do know the specifics of what could be triggering and not.
Right. And not just to scare the kids, because some of these presentations can be so traumatizing to a sensitive kid that may be the
I
take home
think that's
message.
true. And I think it can be. And I think we're talking about how to live, really a healthy life,
Right.
a lifestyle, and how do we take care of ourselves and our body and be compassionate to our body and ourselves. I think, it's not just what not to do, but it's also what we can do to live the kind of lifestyle we want. And how I just want to say one more thing about this. It is important, I think, again, in the religious world, like around, and maybe also in the secular world, like there is a lot of pressure on being a certain size for dating and shidduchim. And
Mm,
I think that as a community, we really need to address that. Because it's very real. I
yeah.
teach a class on eating disorders, and I have a shadchan come in, actually, a matchmaker come in, and she talks about how much sometimes the boys are pretty insistent on having a girl of
Mhm.
a certain size, and she tries to talk them through it and help them to be more open. But I think as a community, we need to be thinking about that and how to address that because many people are not meant to be a certain size, and to be that size, they have to have an eating disorder. They have to be anorexic or bulimic, and we don't want to be a community that promotes that. We have to really be more accepting of different sizes and
Mhm.
see really the beauty in different sizes and help people see the beauty in different sizes.
That is so beautifully said. And again, go back to my podcast. I've done so many. Miriam Pascal Cohen has been amazing voice for removing weight stigma from our community and not focusing on body size.
Wonderful.
She's
Great.
amazing. And I interviewed her. So
Okay, great. So everybody
I
can
could link
and
10
listen to
talks
that.
to this. I could link
Yeah,
10
yeah.
talks to this.
Please
We've
do.
done
I think it'd
so
be great for
much.
everybody.
We've done so much and we can't really do enough of it. But I think the take home point from this, and I just want to reiterate it, is that the fear should not be the known kid in treatment, right? That is a model for everybody else that if you have a problem, you get help and we support you. That's it.
100%, 100%. And ignoring a problem, even though the fears, I understand people might have fears about acknowledging a problem, but ignoring it will probably make it worse.
Right. And that segues into the kid who is maybe diagnosed but resistant, right? Or not doing well in therapy. And that can be a challenge, right?
Yeah, I think it really can. I mean, for we know, or and not everybody does know that often anorexia is a disorder that people are in denial of. They don't think it's a problem. When people come into my office because they're depressed, they wanna feel better, right? But when people come with anorexia, they're like, I don't know what's wrong. I'm fine. My mom wants me to come here, right? So there's a lot of resistance. Sometimes you might feel that with bulimia as well, but certainly with anorexia, it's very common. So it does become very challenging to help somebody who doesn't feel like they need help
Right.
and is forced into therapy. So, the first stage of treatment for anorexia and bulimia is stopping the disordered behavior, rather that's like restricting food or purging. So even if they're not ready to get into the possibly the psychological piece that might be contributing to it, at least if we can work on stopping the behavior, um, of gaining weight for an anorexic, because it does affect cognitive ability, and in addition to medical issues, they're not thinking correctly. And for bulimia, also to just stop that binge purge cycle. That if we can stop the behavior, I mean, binge eating too, I'm less worried about their cognitive ability. But then after that, with a good alliance and connection, which is so much a part of good therapy, they might start to be able to be more open about, things that they're struggling with.
Right. And back to that kid who's not really doing well, I'm going to say that, there may be a resistance to go to higher level care. And nobody's doing anybody a favor by keeping a kid in a mainstream setting when they need something more intensive.
Right, 100%, 100%. And, just to say it again, if you catch it early, you can probably deal with it outpatient,
Right.
which means, just seeing a therapist and a nutritionist and your doctor, and they could still be in school and see friends. So that's why once you don't do that, then we're looking at it's going to get more severe. And then you might have to do day program or residential, which by the way is not horrible. If you have to do it, it's okay. Like that can help also. And just trying to prevent that.
Right. But if you're not adequately treating it, this is a very malignant
Yeah, it
disease.
is. It is, and I don't want to scare people, but sometimes I'll see people that are 50 years old that have had it for
Right.
35 years, and then it becomes like really, really hard to have any kind of improvement when an eating disorder has lasted for so long.
Right, right. So I'm going to end here and I'll tell you why, because I know you're busy. So I'm not going to go into recovery and avoiding triggers, which is something I did want to talk about. So I'm going to save that for my next eating therapist. But I want to thank you so, so much for doing this with me. And I want to wish you a good Shabbos and a Gemar Chasima Tova.
Yeah, thank you so much. You as well, and thank you everybody that's listening. And thank you so much for interviewing me. It was a pleasure.
Absolutely. Be well.
Thanks for listening to the JOWMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOWMA_org. Check out our website, www.jowma.org, that's JOWMA.org, or email us at health@jowma.org.